Okay, so we have several different forms that we use for admitting patients to the hospital. So our first form is our anesthesia consent form. So, excuse me, this form outlines the things that we do for our surgery patients as far as doing an IV catheter for every procedure over 5 minutes and using multimodal analgesia so that we make sure that our patients are comfortable. So this has some places here for us to fill in. So the computer automatically fills in our patient information. So this is on a particular patient. His name is Chopper. He's an 8-year-old male neuter Chihuahua, and it also puts in his patient number so that we can refer it back to his chart if needed. We have a place to write in what his scheduled procedure is, as well as if we've given an estimate for that procedure or not, whether he's had the required pre-anesthetic lab work, and whether he seems to feel okay today. So we want to make sure that he's not feeling poorly, that the owners haven't noticed anything amiss that might derail our surgical procedure. The next section that we have is for any additional procedures that we're wanting to perform. So if the owner would like us to microchip their pet, or to express their anal glands, or check their skin, or anything else that we need to do, we have a section here. We have a couple of pre-printed things that we can choose, or we have a write-in area that we can put in here. The next section says that the pet did not eat after 10 p.m. last night. That is our cutoff for our anesthesia patients. It's okay for them to have water after that point, but we don't want them to eat any solid food past that point. If for some reason they did get food after that point, we have a place where we can write in when they were fed, and then it would be doctor's discretion as to whether they want to postpone the procedure or go ahead, depending on when the pet ate and what they ate. The next line refers to medications, so we want to know, A, are they on any daily medications, and if they are, did they receive them today? For some things like seizure medications, we want to make sure that the patients get those as scheduled, even if they're going to have an anesthetic procedure, so we need to know if they've had those. And then we have some contact information for the owner, so we want to know the best number to get in touch with the owner while the patient is here, in case there are questions, or if we have any complications, if we need to contact the owner. The next box talks about the fact that with all anesthesias there are risks up to and including death, so we want to make sure that the owners are aware of that and aware that if they have any questions or concerns, they need to talk to the doctor prior to the procedure so that they can get those questions answered, or we can further clarify what the procedure is. It also authorizes us to perform CPR should the patient arrest while they're under anesthesia, and just says that the owner understands that they're financially responsible for the procedure as performed. There's a place for them to sign, and then the computer automatically fills in the date for us so that we know what date this procedure was for. This all gets scanned into the record and gets attached. We're a paper light clinic. We try to keep as little paper as possible, so pretty much everything that we do gets scanned in and attached to the record. All of our medical records are digital, so we have an electronic medical record. So we sign into our Avamark software, and this is what we see. So we have to put in a password in order to access our medical records. Once our software comes up, we have all of the information that we need. So we have the owner's information as well as the pet's information and all of their medical records. Everything is put in by the date and time, as well as what we've done and who initiated the procedure. And then for previous records, we have a code that we attach their previous records to once we scan them. So we're able to pull those up as a PDF file and able to access any previous records that this pet has had, so that we have everything as a permanent medical record. So this is how we make sure that everything stays as it needs to be, and we have records on all of our patients. This is a secondary consent form for this particular patient. This is a consent form for our dental radiographs, so it talks about why dental radiographs are important, as well as the reasons that we recommend it, so that we can fully assess the teeth and make needed recommendations. So we've got a place for them to sign to authorize the radiographs, as well as a place to sign that says that they understand that we may find things that need to be addressed, and that we may need to schedule a second procedure to fully address everything. Alternately, they can decline the x-rays, or if there's a specific tooth that we're concerned about, they can authorize us to only take x-rays of that tooth and the contralateral tooth for comparison. They can also just fully decline all x-rays, and in that case it does say that they understand that it is a compromised level of care and that there may be things that we cannot address because we don't know about them, because we did not have the ability to do the dental radiographs. For patient identification purposes, we use a cage card with a printed label that has the owner's information as well as the pet signalment, and then we write on the card exactly what procedure we're going to be doing so that we have that on record. We are a pretty low volume clinic. We're just one doctor, so we usually don't have more than 2 or 3 surgery patients at any given time. So this hangs on the front of the cage and is their identification, and tells us what procedure we're going to be doing today. Because we're a paper-light practice, we generate our accession forms via the computer. So we actually go in and put in what panel we're going to run, and then we print this directly from the computer. This is linked to the Antec website. It's also in the patient chart, so as those results come back, they will actually automatically upload into our system and attach so that we have them available at all times. And if we choose to print it out from the computer, this is what it looks like. So it prints out our serum chemistries as well as our CBC and our PT and PTT time. This was a pre-anesthetic panel. So it gives us a nice printout as far as if there are any abnormalities. And his pre-anesthetic lab work was pretty good. He had a little bit of an increase in lymphocytes and monocytes, but it wasn't anything that the doctor was concerned about for this dental procedure. So we're going to go ahead and get him prepped and ready for surgery and get him into his dental procedure. Once we have our patient admitted, we've gone through the consent forms with them. We take them into a room, we get a current weight on them, we go ahead and get a temperature on them because we want to make sure that they are doing well, that there aren't any potential issues prior to the procedure. If they had an infection of some sort, we don't want that to compromise our level of care. Once we have all of that information, we fill out this sheet. It has our pre-anesthetic doses, our induction doses, our pain medication doses, has everything that calculates automatically based on their weight. But we put in the client's information, the pet's information, what they're here for. We put in today's weight. We have an area to list any known issues. So if they have seizures, if they're diabetic, if they have Cushing's disease, anything that could impact the anesthesia, we're going to put that there. We also have a place to list previous anesthesias. So if we've anesthetized this patient before, we want to know what when it was done, what drugs were given, and if there were any complications. So if the dog was hypothermic, if the dog had a heart block, if there was something that happened during the anesthesia that was not normal, we want to know that so that we can potentially change what we're using this time and hopefully avoid those complications. So once we input the weight up here, it's going to automatically calculate our doses. We have the automatically calculated doses. We have the next column is the dose that we are actually giving. So in some instances we will adjust these doses based on our patient and based on the protocol that the doctor wants to use. So we write the actual dose that we gave. We write down what route we gave it by. So we typically give our pre-anesthetic doses via IM injection and then give our induction doses via IV injection. So we write those down in this column, and then we have a place to put in what time they were given so that all of this becomes part of the record. This sheet will also automatically calculate emergency doses. So just in case there's a complication during the anesthesia, we have doses of atropine and lidocaine and epinephrine and several other emergency drugs that are pre-calculated for us so that we can access those drugs very quickly and hopefully stop whatever the complication is. And then this big section here is for anesthetic monitoring. We have a technician that's monitoring the anesthesia throughout the entire procedure. They're keeping a constant eye on all of the vital signs and alerting the doctor if there are any changes. And then we do actually record all of these vital signs every 10 minutes so that it all gets input into the record when this gets scanned. Down along the bottom we have some extra information if we have to give any post-surgical drugs, if we have to give any reversals or additional pain medications, we have those down here. We also have sections to note IV catheter size and site, as well as the endotracheal tube. We note what size tube we use so that in future anesthesias we know what size tube worked previously and we can start with that instead of having to potentially do some trial and error to get the correct size. So that's our anesthesia form that we use for monitoring. For discharge instructions, it depends on what the patient was here for, but there are some general surgical discharge that we go over. So for any pet that's been anesthetized, we warn the owner that they may be groggy for the rest of the day, so we do want them to keep them protected and indoors preferably. They often don't regulate body temperature as well. They may do things that jump off furniture or something like that where they could hurt themselves, so we want them to be somewhat supervised for the rest of the day if they're going home from a same-day procedure. When they take them home, we want them to start them with just some water. If they're doing well with that, they can have a little bit of food later that evening, but we want a light meal in their stomach because of the anesthesia. If they have any sort of surgery that has an incision, like a spay, neuter, or tumor removal, we want them to check the incision on a regular basis, at least twice a day. Make sure that there's no redness, swelling, or discharge from the incision, and that it's all laying together nicely like it should. We show the incision to the owner prior to them leaving so that they know what it looks like and what it should look like. And then we encourage them that if anything seems amiss, if the dog feels sickly or isn't wanting to eat or drink or seems to be bothering the incision, we need to know about that. If they're bothering the incision excessively, they may need a restraint device such as an Elizabethan collar or a bite knot collar, and that's something that we'll dispense as needed. We tend to not send it home with every pet. Most of them don't bother their incisions from us, but we do have them on hand in case we need to send them home. For dental patients, if they've had major extractions, we do give some instructions for feeding a softened diet for a few days, warning them that they may see some bloody discharge from the pet's mouth, especially when eating or drinking for a few days, and then that's all normal. But if they're not eating well, or if they're refusing even softened food after the first 12 to 14 hours, we need to know about that because those patients may be in some extra discomfort. We typically don't send medications home for routine procedures, spays, neuters, tumor removals. We do a lot of preemptive analgesia, so they don't need as much as they go home, but we will sometimes send medications home with orthopedic procedures or some of the more extensive dental extractions that we do. We'll send home pain medications and or antibiotics, so we go over those at discharge as far as how often to give the medication, whether they're needing to give it, if it's a once a day medication, do they need to give it in the morning or at night, does it need to go with or without food, and if they've already had any doses for that day so that the owners know when they need to give the next dose. So we go over all of those with the owners when they come to pick up for discharge. Some specialized surgeries like cystotomies, we might need to tell them that the pet may have some hematuria for a few days. As those incisions heal, the pet may need to go out more frequently since they have had surgery on their bladder. Anything that has external skin sutures, we remove those in 10 to 14 days. Things like our spays and neuters typically have buried sutures, so there aren't any sutures to remove on that. So that's our basic discharge instructions. Obviously, they may change based on a specific patient or a specific procedure, but for the most part, a lot of our surgeries are very general instructions as far as watching things and making sure that everything's healing like it's supposed to. So we're going to restrain a cat for a jugular blood draw. So we're going to take our outside arm and we're going to reach down and we're going to grasp the elbows, and I've got a finger between to separate, and then I'm going to take my other hand and capture his head and hold him in an extended position so that the person that's drawing blood can access the jugular vein. So we're going to restrain this kitty cat for a cephalic draw. So I'm going to hold his head close to my body. I'm going to extend this front leg, and I'm going to hold the vein off at his elbow so that they can access the cephalic vein. So to draw from a saphenous vein in a cat, to hold off, you want to scruff the kitty and lay them on their side. The leg that is down, you're going to take your hand and kind of in a karate chop motion, you're going to put pressure to occlude the medial saphenous so that the person drawing the blood can access the vein. Okay, so when we're getting a patient in and out of a cage, especially a top cage, number one, you want to have reasonable belief that your patient is nice. If not, there are some special things that you can do. Sometimes covering them with a towel will help, or even lassoing them with a quick leash, and then you can hold their head away from you as you pull them out. This is Maxwell, and he's a pretty well-behaved guy, so we're just going to go ahead and get him out of this cage. So we're going to open up. We're going to kind of put our hand in as we open so that he can't run out the front. Hi, Maxwell. So we're just going to kind of bring him to the front of the cage. And then as we bring him out, we're going to support his front and back end. And then to put him back in the cage, we're just going to basically reverse the process. So we're going to put his front end in first and support him the rest of the way in so that he doesn't hurt himself trying to leap away from us. So this is Maxwell. He's going to be our model for how to apply a muzzle to a dog. This is a pretty standard nylon muzzle. It has a clip here that goes around behind their ears and snaps in. It has an adjustment to make sure that it's snug. There are two pieces to the muzzle. There's a short part that goes over the top and then a longer part that goes under the bottom jaw. So you would take this and you hold it by the straps and you kind of come up over the nose and scoop it under. You snap it around behind their ears and then you pull the tail in order to secure the muzzle, and you want the muzzle to be appropriately sized so that it holds their mouth closed. If it's too big, then they can still get their mouth open and still potentially bite someone. So Maxwell did a very good job. When you release this, you want to have your hands away from the pet's face. You want to unclip it, and then you basically just pull on this long end to pull it off of their nose so that you don't have your hands anywhere near their face where they could potentially bite you. Okay, so we're going to apply an e-collar to our patient here. So we've chosen an e-collar that will reach past his nose once it's on. So we're going to put his head through the opening here, and then this particular model has a tie that we're going to use. So we're going to tighten this down, and we want it to be pretty snug so that it can't slip over his head. And so we're going to tie this under here. We want to ensure that our measurement is good so his nose doesn't extend beyond the e-collar. And then we want to give it a tug and make sure that it doesn't come off over his head. So this is an e-collar on a patient. He's obviously not real thrilled about that. Okay, so this is Maxwell. He's here today for a dental procedure. So I'm going to go ahead and do a pre-anesthetic exam on him. I'm going to look at his eyes, make sure everything looks nice and clear, that his sclera is nice and white. He does have a meibomian here on this eyelid. We're going to be taking care of that while he's anesthetized. His nose is nice and clear, no discharge. I'm going to look at his teeth and check his gum color. I'm also going to check his capillary refill time, which is normal. He does have some moderate to focally severe tartar on his teeth. As I said, that's why he's here today. I'm going to look down his throat as best I can. Everything looks normal in there. I'm going to palpate some lymph nodes, make sure that nothing is enlarged and everything is as symmetrical as can be. I'm just going to kind of run my hands down the rest of him here. I'm going to stand him up and I'm going to palpate his belly, make sure that I don't feel any lumps or that he's not painful anywhere. Make sure that his bladder is a normal size, and it is. I'm going to feel some lymph nodes back here. Check his little bottom. We've already taken his temperature as well as gotten a weight on him, which were both normal. We're going to check his genitals here, and that looks good as well. And now I'm going to listen to his heart and lungs, make sure that I don't hear any murmurs or any crackles or wheezes in his lungs that would indicate that anesthesia is not in his best interest. So we're going to start with his chest here. so his heart sounds good. He's got a nice normal rhythm and a nice normal sound. It's getting a good, there's no murmur or anything present there. Listening to all of his lung fields. Making sure that I hear air in each quadrant. That there are no silent fields and that there are no crackles or wheezes. Everything sounds good there. I'm going to pull up my stopwatch here. And I'm going to go ahead and get a heart rate. Counted 45 beats in 30 seconds, so his heart rate is about 90, which is pretty normal. So everything looks good. He looks like he's ready for his procedure today. We are going to be using a combination of medications. His pre-anesthetic is going to be a combination of butorphanol and dexdomitor. That will give some mild analgesia properties as well as some sedation, make him more amenable to us putting in his IV catheter. His induction is going to be ketamine and midazolam. That's our standard induction for pets that don't have contraindications or thing would be a consideration for propofol. You know, if he had a heart murmur, if he were diabetic, if he had major respiratory issues, we would be considering using propofol since it's a lot faster acting. But for him, we're going to do ketamine midazolam. We're not expecting any major analgesia need for him. We're not expecting any major extractions. We're not doing any major surgery on him, so the butorphanol should be adequate for that. And then, you know, he's probably not going to need to go home on any analgesia, as long as, again, we don't find anything in his dental cleaning that would say that we need to do something more for analgesia. So he's going to go back in a cage until we're ready to start with his pre-anesthetics, and then we'll get those going and get him anesthetized. Based on our physical exam, we assigned an ASA grade of 1 to Max for his dental procedure. So this is Fred. He's going to be getting neutered today. So we're going to go ahead and do our pre-anesthetic exam. So I'm going to look at his eyes, make sure they look clear and the sclera is white. I'm going to look at his teeth and his gum color, and I'm going to assess his capillary refill time, which is good. Come here, Fred. I'm going to take a peek at the back of his mouth. I'm going to feel some lymph nodes, make sure that nothing is swollen, that everything is symmetrical. I'm going to palpate his abdomen, make sure that there are no masses or tender spots. Away. Take a look at his bottom. And we're going to make sure that he has 2, and he does. And then we're going to go ahead and listen to heart and lungs, and we want to make sure that there are no murmurs and that there are no crackles or wheezes present in the lungs. Okay, heart sounds good. Listen to some lung fields here. Okay, everything sounds good there. I'm going to pull up my stopwatch and get a heart rate here. Counted 60 beats in 30 seconds, which makes his heart rate 120, which is normal for a kitty cat. So we're going to go ahead and get his sedation and induction drugs ready. He's going to be getting buprenorphine for some analgesia. He's going to be getting some butorphanol, which is also analgesia, and a little bit of sedation. He'll get dexmedetomidine, which is a sedative, and he'll get some ketamine as an induction agent, and then we'll get him set up and ready for his snooter. Based on his physical exam, we assigned an ASA grade of 1 to Fred for his neuter procedure. Okay, so we're going to draw blood from his cephalic vein. So I'm going to wet this with alcohol, and she is occluding the vessel. We're going to palpate our vessel here and then bevel up. Bring it right into it. Give a draw back on the syringe, and we have our blood sample. We're going to be doing a cephalic draw on this kitty here. So Miss Paula's going to hold for me and occlude the vein. And we're going to put a little alcohol on, palpate the vein, and then we're going to go in, bevel up. You're okay, you're okay. And we have our blood sample. So today we're going to be getting a sample from Smith here. We're going to be doing some serum chemistry testing. So I'm going to do a jugular stick to get my blood sample. I have a green top, a red top, and a purple top ready for my blood to go into. So I'm first going to wet with some alcohol here. I'm going to occlude the vessel down here in his thoracic inlet and feel for the vein. So I have the vein right there. I make sure that my bevel is facing up, and I'm using a 20 gauge needle, which is a pretty good sized needle. I want to minimize any cell damage as I make my draw. I'm going to do a jugular draw on this kitty. So Paula's going to restrain for me, and we're going to occlude the vein here at the thoracic inlet, and I'm going to wet this neck with a bit of alcohol and see if I can palpate this vein. Okay. Once I palpate the vein, I'm going to take my needle, bevel side up, and I'm going to insert it. And then I'm just going to gently draw back. Okay, so we're going to pull from the saphenous vein here, so bevel up, and we're going to go in. There we go. And this is just for a heartworm test, so we don't need much sample for this. Okay, so we're going to be doing a draw from a medial saphenous on this kitten. So I'm going to go ahead and wet down with some alcohol here, and then Paula's going to occlude the vein for me. I'm going to take my syringe and bevel side up. We're going to palpate the vein, and then once we're in the vein, you want to pull back kind of slowly on these guys. A lot of times these little kittens, especially this medial saphenous, will collapse if you pull back too hard. But we've got our blood sample. So when we're talking about a minimum database for our surgical patients, we want to be looking at a packed cell volume, a total protein, blood glucose, BUN, and ALT. So we want to look at a packed cell volume to assess for any anemia or potential dehydration that might be there. We also want to look at the total protein to make sure that protein levels are normal. If they have low protein, then there could be issues with keeping blood volume and fluid volume in the vessels. If they have a high protein, that could affect how the anesthetics work. Low protein as well. A lot of our anesthetic agents are protein bound, so we want to make sure that those levels are normal before we initiate an anesthetic procedure. We want to check a blood glucose to make sure that we're not dealing with a diabetic, or that we don't have a patient, especially a young patient or a growing patient, that has a low blood glucose, because that can certainly cause some major complications with anesthesia and recovery. We want to check a BUN to make sure that our kidneys are functioning properly. If we have a kidney compromised patient, that can affect what anesthetics we want to use, because a lot of those anesthetics are filtered through the kidneys. By the same token, we also want to check an ALT, which is liver specific, and we want to make sure that there aren't any liver issues that we don't know about, because that can greatly affect how the anesthesia is metabolized as well. So that's kind of our minimum database for patients. For patients that are sick or geriatric, we want to add some other things on. So we may want to check pancreatic specific lipase if we're dealing with a potential pancreatitis patient. We may want to do fecal testing or parvo testing for a puppy that's vomiting or having diarrhea. We might want to do some EKG if we have a patient with a cardiac murmur, or if the doctor hears a rhythm that's not normal, or we might want to do some radiographs if we have a patient that either has crackles or wheezes in their lungs, or has a cough, or even potentially the vomiting and diarrhea patient. We want to make sure that, are we dealing with foreign body? Are we dealing with an intussusception? Is there something else going on that we need to know about? So we might add those on, usually at the doctor's discretion, for a patient that has an abnormal physical exam, or if any of their values on the minimum database are abnormal. Okay, so we are going to fill out our controlled substance log for our surgery that we just did. So in the mornings, we go ahead and fill in our surgery so that we make sure that we get entries in. So today's the 17th. This pet's last name is Anderson. The pet's name is Fergus. He was here for a diaphragmatic hernia repair. So we're going to notate his controlled substances. So he received 0.33 mils of buprenorphine. So we're going to come onto our sheet here, and under buprenorphine, we're going to put in 0.33. And then he got 0.11 of butorphanol. So we're going to come across our thing here and find butorphanol. So he got 0.11 of that. Dexmedetomidine is not controlled, so we don't have to notate that. Ketamine, he got 0.1. And then midazolam, he got 0.33. So those are all of the controlled substances that he received today, so we have those notated on here as our anesthetic drug log for controlled substances. We have central oxygen, so these are our large H tanks. They feed up to a pressure regulator that then feeds up into our central oxygen, and we have outlets at all of our stations where we can attach our anesthetic machines to the oxygen supply. Okay, so this is our anesthesia machine. We have our central oxygen line here, so we're plugged in and can receive oxygen from our system, and it comes in through the back of the machine here into our flow regulator. So we turn this knob here, and there's a bearing in here that comes up and shows us how much oxygen is flowing through the system. This is our vaporizer. This is for isoflurane. You can monitor the isoflurane level here. You fill it here. This knob up here turns to adjust the percentage of isoflurane that is being administered to the patient. We have our inhalation one-way valve here and our exhalation one-way valve here. This allows them to breathe in fresh gas, and then as they exhale, it comes to the reservoir bag. Our tubing, we use a tube within a tube system, so one delivers the fresh gas to the patient, and then the other delivers the gases that are exhaled back to the system. Behind our reservoir bag here, we have our soda lime canister. This functions to filter out the CO2 from the system as the patient is breathing. This is a rebreathing system. the fresh gas, this is the fresh gas outlet here. If we were using a non-rebreathing system, we would take this tubing off. We would hook the new tubing in here, and then our fresh gas tube would go here. And in that system, they breathe in the fresh air. The exhaled air goes straight into the F-air canister to be filtered into room air. They don't rebreathe that at all. With this system, they're rebreathing some of the gas that that's coming through the system. And then this is our relief valve and our pop-off valve. And then this goes down into an F-air canister, which sits in a holder down below. This is our scavenging system. So this removes the isoflurane from the gas before it's let back out into room air. That does need to be weighed on a regular basis and replaced anytime replaced on a regular basis. It has to do with how much weight it gains as far as when it needs to be replaced. We do have a sevoflurane vaporizer here that we can hook into the system. We actually don't use this very often. We primarily use our isoflurane. So this is our pressure manometer. So this tells us how much pressure is on the system at any given time. So when we're giving a breath to a patient, we're holding off our pop-off valve, we're squeezing our reservoir bag, and you don't ever want to go above the 20 centimeters of H2O because that would be too much pressure on the lungs. So we're going to go ahead and do a quick pressure test on this. So I'm going to occlude the end of my tube with my thumb. I'm going to turn on my oxygen, and I'm going to push this flush button to put a little bit of oxygen into my reservoir bag. I'm going to depress my pop-off valve and squeeze my bag, and I want to make sure that it will hold pressure. So if there were a leak in the system that would not hold pressure, that needle would go down, and that would indicate that somewhere in the system there's a leak. So just to do it again, so we're going to just push up and it's holding without any additional pressure on the bag, so that indicates that the system is sealed, that I don't have any leaks. Common places for leaks would be either connections, any one of the connections, or the reservoir bags will sometimes get a hole in them, and that would be something. Also, when you change the soda lime, occasionally when you're putting that back on, you'll get a little bit of grit stuck in the threads. That can cause a leak as well, so you want to check all of those areas. If you can't find the leak, the machine should not be used until it can be serviced by someone that can repair anything that needs to be repaired. So when we're talking about induction of anesthesia, most commonly we're going to use an IV induction agent. We do use an IM induction agent in cats, but you also have the ability to use an induction chamber. So they often look a lot like a fish tank, and they have a port for the gas and vaporized anesthesia to go in on one side, and then a waste port on the other that goes into your scavenging system. And you typically want to limit usage of those as much as possible. They do often result in a lot of waste gas being let out into the environment, so we don't like to use them very much, but you can use them for either pocket pets or other feral cats, things like that. And then you can also use a mask for induction. We don't like to do that either because, again, you end up with some waste gas that ends up in the environment. But you can use a nice snug-fitting mask over the mouth of the patient, or over the mouth and nose of the patient, and use that in order to gas down a patient. We don't like using gas anesthesia as an induction because it often results in a slower transition from consciousness to surgical anesthesia, and that can be a detriment to the pet because it's stressful and there's a lot more involved as far as the passage is much slower. So you can use those, but we don't typically, we try not to if possible. This is a pulse oximeter, so we are going to put this on the tongue or lip or sometimes a toe, any other thin part of skin that is light color, and it has a diode on one side and a receptor on the other. This is going to measure the percentage of hemoglobin that has oxygen bound to it. This is an esophageal stethoscope, so this probe is passed down the esophagus of the patient and lies just over the heart. We hook this end onto this connector here, and then we're able to put the stethoscope in our ears and actually hear the heartbeat directly that way, rather than having to go under drapes potentially to listen through the chest wall. So this is often used in surgery if you're needing to listen to the heart rather than having to try and use an external stethoscope. These are EKG leads. We're going to hook these onto the appropriate points on our patient. So typically it's going to be in the axillary region, on the flanks, and then this has one that goes in the center of the chest. These are going to measure electrical signals in the heart and how they're flowing through the heart. This allows us to monitor the rate as well as the rhythm of the heart, as well as looking for any sort of heart blocks or arrhythmias that might be due to electrical conduction issues within the heart, so that we can hopefully remedy those either with drugs or by bringing the patient out of anesthesia. So for endotracheal tubes, you want to choose a size that's appropriate for your patient. You can estimate the size of the patient's trachea by looking between their nares and get a general idea. Brightest palate breeds typically will be a bit smaller than you would assume, and the long-nosed breeds like greyhounds are often going to be a bit larger. So you get kind of a general idea. You want to have a couple of sizes available if you haven't intubated this patient before, so that you can have other options if needed. You always want to pressure test your cuffs, so we have syringes that we use to inflate our cuffs. You would inflate the cuff, and then you would submerge this in water along the full length, so that you can make sure that there are no air leaks either around the cuff or around the tubing that goes to it, or around this one-way valve, or not one-way valve, but the valve here that keeps it inflated. As long as there are no leaks, you can go ahead and use that tube. You do want to also measure for length, so you want to measure from about the thoracic inlet to the end to the patient's nose, so that you make sure that you don't have a tube that's drastically too long, or by the same manner a tube that's too short. These tubes can be cut in order to make them an appropriate length if needed, but you want to do that measurement before you intubate, so that you know how deeply into the chest you want to go. This is our respiratory monitor, so we have an apnea alarm that alerts us if the patient has not taken a breath in a preset time frame. So we have a sensor here that goes on the end of our rebreathing tube, and it has a sensor that hangs out in the middle here that is going to sense as the air passes due to inhalation and exhalation. And then this timer it counts up. When it gets to the preset time, in this case 20 seconds, it will beep to let us know that the patient has not taken a breath. We can adjust this to various levels. As a standard, we have it on every 20 seconds, but we can adjust it if needed based on the patient. This is our blood pressure monitor. This is an HDO unit. It comes with several different cuff sizes. What we end up doing with this is we put this cuff around preferably a tail. If not a tail, we put it around a front leg. We want it to be a snug fit but not too tight. If it's too loose, it also won't read as well either. So we choose an appropriate cuff size. We plug the cuff into the machine here, and then this machine is turned on. It's actually hooked into a computer that will show us the waveform of the blood pressure. It's an oscillometric reading, and this will give us a systolic, a diastolic, and a mean arterial pressure, as well as a pulse rate. And we can set this to cycle as many times as we want. We particularly, in our system, we like to do it every 3 minutes. So this will give us our non-invasive blood pressure reading on our surgery patients. We can also use this on non-surgery patients. If we're trying to get a blood pressure on a hyperthyroid cat or a kidney failure dog, we can use this machine on those awake patients as well. This is an esophageal thermometer probe. So this end plugs into our monitor here, and then this end gets some lube and gets passed into the esophagus. This is going to measure the core temperature of our patient while they're anesthetized, so that we can monitor for hyperthermia, or more commonly hypothermia, where we need to do some supplemental warming of the patient to keep them from getting too cold. This is my preceptor, Dr. Gerard Clark. We've worked together for the past 7 years. He's done all of my preceptorship for my classes. Okay, so we're going to be placing an IV catheter in our patient. So we're going to go ahead and shave first. And I'm shaving with a 40 blade. And we want to shave a window that's large enough for our catheter. So that none of our catheter or cap or anything is touching hair once it's placed. So we're going to get rid of all this extra here. So now we're going to do our scrub for our catheter. And so we're going to do a 3-time scrub with Chlorohex with alcohol as our rinse. Now that we have that completed, we're going to go ahead and put our catheter in. So I've got my catheter and a cap, as well as some saline flush, and I've got my tape already torn and ready. So she's going to hold off this cephalic vein for me, and I'm going to just first palpate this vein. And we're going to remove our catheter from the cap, and we're going to make sure that our bevel is facing up. We're going to insert our catheter into the vein, and we get a nice flashback. And then we're going to advance our catheter off our needle. And then we're going to take our cap and we're going to, whoops, not do that. We're going to remove our needle and screw our cap on, and then we're going to go ahead and tape this. So we're going to take our first piece of 1/2-inch tape, we're going to put it sticky side up underneath the catheter, cross this over, try and get some of this hair out of the way. Make sure our cap is on nice and tight, and then our second piece here is going to go sticky side down underneath the cap. And over top here. And I'm making sure that none of my tape is over the top of my cap, so if I needed to remove this to plug in an IV line, I can. And then I'm going to take my saline flush and flush this catheter, and I'm looking to make sure that the flush flows easily, as well as there are no swellings that come up above the catheter that would indicate that I'm outside the vein. You can also place your finger lightly over the vein and pulse your flush so that you can actually feel it moving through the vein as you're doing that. Okay, so we are going to do a medial saphenous catheter on this cat. She's having an eval. So we're going to go ahead and shave. To do a 3-time scrub. This is a cap, so I'm going to use iodine as my scrub. And I'm going to go in a bullseye pattern just like we would for the surgery, and I've got alcohol here that I'm going to do in between. If your patient is particularly dirty, you may need to do it a couple of extra times just to ensure cleanliness. So now that we've got that scrubbed, I'm going to go ahead and get ready to place my catheter. I have a couple of different sizes here. I was just kind of looking to see what this vein looks like. Pretty small veins. We're going to go with this. So we're going to take our catheter out of the cap. I'm going to make sure that the bevel is up. This particular catheter has a paper filter, so I can leave the back cap on it. So I'm going to stabilize the leg and the vein and bevel up. I'm going to insert into the vein. And then once I get a flash, I'm going to go ahead and advance. She's going to let up her pressure on the occlusion and then just stabilize the catheter for me. I'm going to go ahead and place a cap. And then we're going to tape this in. So we're going to take our first piece of 1/2-inch tape and we're going to put it sticky side up and fold it over. That's going to trap the catheter. And then around the leg. And we want this to be stuck, but we don't want it to be occluding the leg. We don't want to cause an issue with that. And then our second piece of tape is going to go sticky side down on the bottom side of the catheter and around the leg this way. We've got courtesy tabs on these, so they'll be easy to take out later on. So now that we have the catheter in, we're going to take some saline and we're going to flush the catheter. And we're looking to see that this catheter flushes easily and that the vein is not blowing, that there aren't any swellings occurring, indicating that the catheter is outside of the vein. And this is flushing very easily. It looks very nice. There's no swelling appearing as if it's out of the vein. So this catheter is placed, and we're going to go ahead and move forward with this CATS procedure. So we're going to give Ellie here a sub-Q injection. So I'm going to pinch her skin here over her shoulders and tent the skin. I'm going to take my needle and go in parallel to her body wall. I'm going to aspirate, make sure that I don't have any blood, and then inject right under the skin. This is Sully. He's our surgical patient today. I have his hydromorphone and dexmedetomidine pre-medication that I'm going to give. I'm going to give this IM. So we do our IM injections in the epaxial muscles. So I'm going to palpate his spine, palpate his ribs. I'm going to go just caudal to his ribs, and I'm going to go just lateral to the spine. And I'm going to put this needle in. I'm going to aspirate back and make sure I don't get any blood, and I don't, and then inject this in. And that's it, and he's a very good boy. Okay, so we're going to be giving this dog an IV injection. So Dana's going to hold this vein for me and occlude the vein. I'm going to wipe with some alcohol and palpate the vein. I'm going to take my needle, bevel side up, insert into the vein. I'm going to pull back and get a flash. She's going to release further up, and then I'm going to slowly inject this medication, and then we're going to hold off once we're finished. Okay, so we're getting ready to induce Sully for anesthesia, so we're going to go ahead and pre-oxygenate him for about 5 minutes before we do his induction and his intubation. So I'm just going to put this mask over his nose, and we're going to turn our oxygen on, and we're going to let him sit, as I said, for about 5 minutes before we do our induction. Okay, so we're going to go ahead and induce anesthesia in our patient here. So we've got our induction agent. We're using ketamine and midazolam. We want to give this to effect. So in this patient, because he's already quite sedated, I've drawn up a smaller dose than the calculated so that we're not giving him a full dose because he doesn't need it. So we're going to go ahead and give this IV. Flush our catheter. And I already have my tube lubricated and ready to go.
Oh, that's okay.
And so we're going to, Boss here is going to hold the top jaw for me. And I'm going to grab his tongue and pull it out. I'm going to take the tip of my endotracheal tube and find his laryngeal folds. And I'm going to pull the epiglottis down with the tip of the tube. And this tube is a little bit big, so we're going to grab our backup tube here. And I'm going to go ahead and get it lubed. And we're going to repeat the process. Okay, so we have our tube in the trachea, and I can visualize that. Make sure that I see laryngeal folds on either side. We're securing this with with IV tubing. And as you see, the tube just comes to the end of his mouth. That way there's no extra anatomical dead space. And so we're going to secure this. We're going to go ahead and position him for his surgical prep. We're going to get him hooked up to this anesthesia machine with some oxygen going. Go ahead and turn on our isoflurane to a low maintenance level here. And then I'm going to inflate this cuff while Ross puts some pressure onto the bag. We're going to inflate the cuff enough that it will hold pressure at 20. But then we don't want it to be so tight that it won't hold, or that it continues to hold pressure after that, because that's the most pressure that we want to have on the lungs at any time. So we've got him intubated. We're going to go ahead and secure him for prep. We're going to get him shaved and ready for his surgery. We're also going to put some monitoring equipment on him while he's out here so that we can keep an eye on things, make sure that his anesthetic depth is adequate. So this cat has had anesthetic induction by IM injection. So we're going to go ahead and place some lubricant eye drops in her eyes. Patients that are sedated or under anesthesia do not blink appropriately, and their secretions are often dried by the medications that we give. So we want to make sure that we keep a good lubrication in those eyes so we don't cause any secondary eye issues. We are prepping this patient for a space, so I'm going to palpate her bladder and express it so that it won't be in the way for the surgeon. And I'm just isolating the bladder in my fingers and giving it a gentle squeeze. So that we get all of this urine out of the way. Okay, so we have our patient induced. She's here for a stay, so we are going to shave her belly. We're going to go from the tip of the xiphoid process down to the pubis, and we're going to go from side to side to the level of the flank so that there's a nice surgical field here. We're using a 40 blade. That's a typical surgical blade. We want to remove as much hair as possible from her belly so that we can get a good strap on it. So now that we have her belly shaved, we're going to run a vacuum over this, and then we're going to run a sticky roller over it to get any excess hair out of the way, and then we'll be ready to scrub her for surgery. Okay, so we have our patient shaved and ready for prep. So we're going to start with Chlorohex soaked gauze. We're going to start in the center where the incision line is, and then we're going to go out in a bullseye pattern. Once you leave the center, you never want to go back. So we're going to go all the way to the edges of our surgical area. And then we're doing alcohol to rinse. And we're going to do this at least 3 times. But you also want to make sure that you're getting the belly nice and clean when you're doing this. Sometimes it will take additional scrubs if the dog is particularly dirty. So we've done our 3-time scrub, and now we're going to move her into our surgical suite. So we're going to disconnect her from our anesthesia machine. Okay. And take these off. Since we're going into the surgical suite, I'm going to take my scrub jacket off so that I'm not contaminated. And then we're going to carry her. And we're making sure not to contaminate our scrubbed area here. You go in first. Thank you. Okay. And now we're going to tie her to the table. So this is mostly for positioning, but it's also just in case she's light on anesthesia. You know, if something were to happen, we don't want her to be able to move around too much. So we have her front legs crossed, and then we're going to half hitch these back legs. And because she's a bigger dog, we're going to come down around the end of the table so that we extend the legs for the surgery. A lot of places will go ahead and do a final sterile scrub now that she's in surgery, just to make sure that there are no contaminants before bringing the doctor in to get ready for surgery. Okay, so Sully is getting his final prep for his neuter procedure. So we're going to do some anesthetic monitoring. So this is our monitoring sheet. So we're keeping an eye on his heart rate, which is indicated here by the EKG strip. We're keeping an eye on his pulse ox, which is here. Right now it's a 99, which is very good. We're keeping an eye on his respiratory rate. So this is an apnea monitor. This will alarm if he goes more than 20 seconds without taking a breath. And then we've also got a temp probe that's in his esophagus, keeping an eye on his temperature. We have a blood pressure machine that's monitoring every 3 minutes. And then we've also got him, he's got an IV catheter, and he's got fluids going for the duration of the procedure. So we've got boxes for all of that to be written down. So we've taken our first reading, we've indicated the time, what his heart rate, respiratory rate, pulse oximetry, his mean arterial pressure, temperature, his IV rate, also what his vaporizer setting is, and then we initial to indicate who took the reading. We're going to continuously monitor this throughout the surgery, and then we're going to record our readings every 10 minutes. This gets scanned into the chart and becomes part of his medical record. If this patient were to go into cardiac arrest, we would begin chest compressions. So on a dog, you're going to put a hand on either side of the chest. You're compressing quite hard. You have to remember that you're actually trying to pump blood mainly up to their brain so that you can keep perfusion going. So you're going to put a hand on either side of the chest, and you can alternately turn them onto their side and compress them that way. Though during surgery, depending on the nature of the surgery, that may not be an option if you've got an open abdomen or something like that. So you're going to compress on either side of the chest. You're going to compress at a pretty steady rate because you want to get that blood perfusing. You're also going to have somebody else that's giving emergency drugs if needed, and you're going to have somebody else that's ventilating the patient at a rate of about 10 breaths per minute, so about every 6 seconds. And you would pause about every 30 seconds to see if you get a rhythm back. And if not, then you're going to continue your chest compressions, continue ventilating the patient, potentially give some additional emergency drugs at the direction of the doctor. So typically when we're performing CPR on a patient, it's an anesthetized patient, so we're going to have them intubated and hooked up to our anesthesia machine. So we're going to be using our pop-off valve and our reservoir bag in order to give breaths as needed per our CPR protocol. But if we need to use an ambu bag, we have one of those as well. So this hooks up to our oxygen supply, this hooks up to our endotracheal tube. There's a dial here to adjust the static pressure, so how much pressure is being held in the system, and then we're going to compress this bag in order to give a breath. We are going to go ahead and get scrubbed in for surgery. So as you can see, I've already got my hat and mask on before I scrub, so that I can stay sterile once I do this. So I'm going to take my finger pick first, clean under my nails. Go ahead and do both hands. Alright. Take my scrub brush, scrub under the nails on both hands. Okay. Then I'm going to flip over to my sponge here. I'm going to do 10 strokes on each surface. So we're going to start, there are 4 surfaces on each finger, so we're going to start here. Then we're going to go to the back. We're going to go to the next finger. And when we get to this inside, we're going to go all the way down the side of the hand. And then we're going to go all the way down our forearm. Okay. And we're going to go to this other hand and do the exact same thing. Now that we've scrubbed everything, we're going to rinse. We're rinsing from our fingertips down to our elbows. We're not going to let the water come back to our fingertips once we rinse them. We're going to start with fingertips. And all the way down. Start with fingertips. that we've done that, we're going to come to our sterile towel that we have laid out here. We're going to pick it up. We're going to start with our one hand. We're going to dry fingers.
What's the last name? And what's the dog's name? And the orange earring.
Then we're going to dry hand. And we're just staying on half of the towel for this arm.
Yeah, it's just
And we're going to go down our arm. Then we're going to grab the other end of the towel and come up and do our other hand. So again, we're going to start with fingers. And hand. And then we're going to work our way down the arm. And once we leave the hand, we never come back. Okay. So we've dried our hands, and now we're going to put our gown on. So I'm going to grab this top part of the gown here and let it unfold as I pick it up. The way this is folded, I'm only touching the inside surfaces. So I'm going to find the first sleeve here, and then I'm going to find the second sleeve here. I'm going to push my arms in, but I'm not going to push my hands through the cuffs. And she's going to tie this for me. Okay, and then I have my gloves already set out. So I'm going to do a close gloving. So without putting my hands through the cuffs, I'm going to pick up this first glove, and I'm going to set it on my hand so that the thumb is facing my palm. I'm going to grab the top cuff through the cuffs of my gown, and I'm going to fold my fingers into the glove, and then push my hand in. And I'm doing this without ever putting my hands through the cuffs so that nothing is contaminated. I'm going to do the same thing on this. I'm going to lay the glove on my hand. I'm going to fold my cuffed fingers into it and pull it over the outside. And each finger in. Once I have the gloves on like this, I'm going to pull my cuffs up. And now that I'm sterilely gloved, I want to keep my hands between my shoulders and my waist so that I do not accidentally contaminate myself. So now we're going to go into the surgery suite. We're going to get our patient draped and our instrument tray set up, get everything ready for surgery. So we have our patient prepared for our ACL surgery, so I'm going to go ahead and open our pack. And we're going to go ahead and drape this leg. So we're going to, we do a 4 towel drape. So we're going to unfold our drape, and we're going to fold it over our fingers so that we're not contaminating our fingers. We're going to place the first drape on this side. We're going to go there. Next, we're going to place our cranial drape. And again, we're going to fold our fingers this way. The next drape we're going to place is going to be on the far side, so we're going to walk around the back of the table, and I'm going to place this here. And then our final drape is going to be across this back side here. And we're going to place that there. Then we're going to take our towel clamps and put them in so that these drapes are held, or these towels are held where they need to be. So we're going to start here. And these are penetrating towel clamps, so we're going to make sure that as we place these, they're going in and they're grabbing skin. That's what ensures that they stay attached to the patient. So when we're in surgery as a sterile assistant, obviously I would be capped and gowned and have my gloves on, but we want to, we would drape the patient and use our towel clamps to secure that, and then we have the rest of our instruments here. So depending on your surgeon, everyone likes their packs laid out a little bit differently, but for this particular doctor, we're going to put our gauze squares to the side. We're going to go ahead and remove our forceps and our scalpel handle and our groove director and lay them out, and then we're going to take all of our ringed instruments and just kind of spread them out by type, and then have our snook hook down here at the bottom so that he can easily access whatever instrument he wants. If the particular doctor likes, you can go ahead and put the scalpel blade on the handle and have it setting to the side. You do want to make sure that all of your sharps are counted for, that you know where they are so that nobody accidentally nicks themselves. Part of a sterile surgical assistant's job is to maintain tissues, whether that's blotting blood to keep the field clear, or keeping abdominal tissues moist when you're doing an exploratory. In this instance, we are finishing up this knee surgery, and so using my sterile gauze, I'm just gently blotting this incision line as the doctor's suturing, so that he can see the different layers that he's trying to oppose. And I'm doing a blotting motion rather than a wiping motion so that I don't dislodge any microclots that are forming and cause additional bleeding. Okay, so we're going to put a scalpel blade on a handle. So I've got needle holders, which are meant for holding metal. I've got it by the back of the blade, and I'm just going to slide it on here until it locks, and then release the blade. To pass this to the surgeon, we want to make sure that that the sharp side of the blade doesn't go towards him or towards me. So we're going to hold it like this, and then we're going to fold it back so that he can take it away safely. When passing a ring-handled instrument, you want to have the box lock between your index and thumb, and the rest of your fingers stabilizing the shaft. And then we're going to pass it in such a manner that when it hits the doctor's hands, it's in a usable position. So in this case, I've got the suture needle here, and it's facing the proper way so that when I hand it to him, it ends up right in his palm how he's going to use it. So part of the duties of a sterile surgical assistant is to receive materials from the circulating nurse. So she's unwrapped this. I'm going to grab this inner wrap and take from her without touching any of the contaminated portions of that outer wrap. If someone breaks sterility during a procedure, either a glove is punctured or an instrument is dropped, you want to make sure to either, if it's a glove, you want to remove those gloves and put new sterile gloves on. If an instrument is dropped, you need to either replace it with a duplicate already sterilized instrument, or it can be flash sterilized if it's the only option that you have. But you want to make sure that if something causes sterility to be broken, that it's addressed immediately and quickly so that there isn't any additional contamination of the sterile field. So we have Fred prepped for his neuter, and we have him up in the positioner. We've got him hooked up to his monitors. We've prepped his testicles. We have some isoflurane available if needed, and we're just waiting on the doctor to come and neuter him. This patient is prepped and ready for a feline spay procedure. We have her scrubbed and connected to all of our monitors, and now we're waiting on the surgeon to come in to perform the surgery. We are cleaning surgery after we're finished with our procedures, either between procedures or when we're finished for the day. The first thing that you want to do is secure any sharps from the pack. So you want to make sure that you have your scalpel blade as well as any needles that were used, and you want to get them first into a sharps container so that they can be disposed of properly and don't cause any unintentional injuries. Once you have that cleared out, you want to clear out any towels or anything else that were used, any surgical packs. Once you're down to just the equipment, you're going to take a rag that you've soaked in whatever antiseptic or disinfectant cleaning solution that you're going to use. So we use a product called Rescue. It's an accelerated hydrogen peroxide. So you want to take a rag soaked in that. We're going to start kind of from the top down and from the center out. So we're going to start with our surgery lights. So we're wiping down all surfaces of our surgery lights. You want to make sure that you're getting the tops as well as the sides, and making sure that you're getting any contaminants that might have gotten on the lights off. So we're going to wipe all those down. Once we have all of our lights done, then we're going to go for the surgery table itself. So we're going to wipe this top portion of it, and then we're also going to wipe all of the other surfaces. So there are all kinds of nooks and crannies on this table. There's also a channel in the V that you want to pull out and clean, and it will run down and into this bucket. So if you had anything that got into this bucket, you'd want to clean that as well. But you're going to wipe all of these surfaces. You're going to wipe all the way around this base and all the way down to the bottom. And then we're going to kind of work out from there. So we're going to wipe down our surgery machine. You want to make sure that you wipe down your rebreathing tubes as well as the machine itself. Any surfaces that are in this room need to be wiped down with this disinfectant solution. And then we're going to wipe down, once we're finished with that, we're going to wipe down our IV pole and all of our pumps, all the way down to the base. You want to get all of the casters and everything so that everything's clean there. We're going to go out and do our other machines. We're going to do our stands and tables. We're going to do our storage in here. We have a stainless steel toolbox that we use for all of our storage. We're going to wipe the tops and sides of that. We're going to wipe all the handles and the fronts. Once we've got everything in here wiped down, we're then going to move things to one side of the room and bring our surgery mop in. Our surgery mop is only used for the operating room so that there aren't any outside contaminants brought in. So we're going to start on one side of the room. We're going to mop, remove everything over, mop the other side. Once everything's dry, then we'll come in and rearrange our equipment, get it back to where it needs to be. Before surgery the next day, we're going to go ahead and come in with an alcohol rag, and we're going to wipe everything down again, make sure that we get any dust off that has settled. Any horizontal surface in the room needs to be wiped, including all of the windowsills, door jambs, all that sort of stuff, so that we make sure to minimize contaminants as much as possible. Okay, so we are going to clean our surgical instruments. So we have them in a tray that comes out of surgery, and we pre-soak them, usually in the fluid from our ultrasonic scaler. And so they've been pre-soaking just to loosen any matter that's on them. And then we're going to take a bristle brush, and we're going to go through and we're going to clean all of the surfaces, paying special attention to the box locks and the ratchets to make sure that there's no blood or other material stuck in any cracks and crevices. As we go through, we're just making sure to get off any debris that might be attached. And then we're going to rinse them thoroughly and put them into our ultrasonic shaker, and they're going to process for several minutes in that to get anything, to cavitate out any additional debris that might be lodged. So we're going to do this, and so we put them in this strainer, we rinse them very well under running water, and then we're going to put them into our shaker and turn it on. So our ultrasonic shaker has finished processing, so we're going to drain this, and then we're going to rinse our instruments well. And then we're going to go over here, we're going to spread them out on this towel and get them ready to lubricate. So our instruments have been dried, so now we're going to use a spray lubricant on them. Some places will have like a bath that you dip them in, but we use this spray. So we're going to spray these box locks top and bottom, and then just kind of work them back and forth so that the lubricant gets in there. And then on these towel clamps, because they are sharp, we're going to snap them closed one ratchet before they're packed. Everything else gets left open so that we make sure that steam gets into all of the grooves, but for those we want to go ahead and snap those closed. So I'm going to go through this pack and lubricate all of these, and then we're going to let these air dry before we actually complete our pack.
Mm-hmm.
Okay, so we are wrapping our surgical pack now that our instruments are clean and dry. So we've got all of our hemostats and our towel clamps. We've got our scalpel handle and our groove director and our thumb forceps. We've got everything lined up nice and neat. We've got our snook hook. We do a 4 towel draping, so we put our towels in our surgical packs. So we're going to lay our instruments across our pack here. We're going to put our gauze squares here, and we're going to put our towels on top. Our steam sterilizer indicator goes here in the center of the pack so that we make sure that the center of the pack is getting adequate steam. And then we're going to do our inner wrap. So this is just a surgical towel that's going to go over here, and then we're going to do our outer wraps. And so we want to get this nice and snug and everything together. So then we're going to start with our inner wrap, and this has little tabs on it so that if a non-sterile circulating nurse is opening the pack, they can open it without contaminating the sterility of the pack itself. So we're going to make sure that those are folded as they should be. And again, we're wrapping everything nice and tight. So as we're doing this, we're wrapping tight and we're holding it in place as we're wrapping. Okay, and then we're going to go ahead and do an envelope fold on this outer wrap. So we're going to set our square pack in the center of our wrap, but we're setting it on an angle so that we've got a corner out to either side and then one at the top and bottom. So we're going to take our one corner and we're going to come up, and again we're going to pull everything nice and tight. This is going to fold over towards us, and then we're going to do our either side. So we're again going to fold over this way nice and tight. Straighten our fold there. This folds back towards the center, and then we do the other side. Again, straightening everything up, and then folding the corner back to center. And then the easiest way to do this is to spin the pack around, and we're going to take this final point here. We're going to make sure everything is folded in nice and snug, and then we're going to bring this all the way up and over, and this excess here is going to tuck in just like you're tucking in an envelope. And so this pack is wrapped and secured. Now we're going to take our steam sterilizer tape. So this tape, when it comes off of the roll, it looks just like regular masking tape, but it actually has steam indicator strips in it. So it's going to, the steam indicator strips are going to turn black once they've reached the proper temperature. And so we're going to put this across this opening of this pack. We're going to go ahead and label this as a spay pack. We're going to put today's date, which is the 18th, and I'm going to go ahead and put my initials on here saying that I packed this particular pack. So we've got this all ready to go into the autoclave. Once we have a few more things, we'll get the autoclave packed, get it run so that this will be ready to go. Okay, so we are going to fold and wrap a gown for surgery. So we're going to take the gown, and it's facing towards us with the arms in. So we're going to fold it kind of front to front here, and we're going to find the armholes, and we are going to hold the top cuff and hold the armholes, and get everything kind of lined up like it's supposed to be. We're going to tuck in any edges here that we see hanging out. Once we have it ready like this, we're going to fold the sides together to make it thinner, and then we're going to accordion fold this up. And what's going to end up happening is we're going to flip it over. We want the top of the gown with the ties to be resting on top, but we're going to take these ties and we're going to kind of gather them up, and we're going to tuck them in so that they don't get contaminated when the person picks up their gown to put it on. So we're going to set it like that. We're going to take our steam sterilizer strip and we're going to put it inside the pack so that we know that this got steam sterilized. We're going to put in a towel, a surgical towel, so that we know that our surgeon has something to dry their hands on. And then we're going to go ahead and we're going to wrap this inner wrap here. And this first one gets a square wrap. And we're going to pull these nice and tight as we wrap. Okay. And then this outer wrap is going to be a envelope fold. So we're going to come up from the bottom, and then we're going to come in from the side. We're going to tuck this edge in here, and then we're going to tuck in over here and come up from the side, and then we're going to spin the whole pack around and take this bottom corner here, just like we did for our surgical pack. And again, we're tucking everything in and holding everything snug, and it comes up and over and tucks in here. And then we're going to use our steam sterilizer tape. We're going to put it across this opening. We're going to write that this is a gown. We're going to put our date and our initials, and this is going to be ready for the autoclave. Okay, so we're going to pack our autoclave with some of our packs that we've wrapped. So when you're loading the autoclave, you want to not fill it too full. You want to make sure that everything can get good steam penetration so that it can be properly sterilized. So we're going to put kind of our big stuff on the bottom here. We've got some paper things here that we're going to put in. This is a bowl that we're sterilizing. We're going to kind of prop this up on the side a little bit so that it makes sure to get steam all around it. As we're putting these paper things in, we're going to pack them in nice and loose so that they can get steam through them as well. And then after we have these all packed, we're going to set our machine and get it ready to run. This particular machine has auto settings that it automatically selects the correct temperature and time and pressure that need to be present for the different types of packs. So you choose what type of pack you have. This is going to be wrapped packs. And then we're going to check our water level, which is up here. If we need to add any, we're going to add distilled water. And then we're going to close our door. This clamp comes over and tightens down in order to seal this, because you need that combination of not only temperature but also the steam and the pressure to get it fully through the packs to get sterility all the way through. Once this beeps and lets you know that it's finished with the cycle, you vent the door so that condensation doesn't build up in the packs as it's cooling down. As far as maintenance goes, for this machine, every 25 cycles, we drain the machine, we run a cleaner through it, and then we drain the machine again, run a cycle with just new clean water, wipe down the inside of the chamber, and then there's a seal here that needs to be replaced periodically if the autoclave is not coming to the proper pressure, if the cycles are failing. And then once these are finished, we're going to let them cool. We'll take them out, make sure that all of our steam strips or all of our steam tape has changed colors to let us know that it reached temperature. And then when you open the new packs, you want to make sure that the strip inside shows that the pack received adequate steam and pressure and time to change the strip to let us know that it's sterile inside. So we're going to go ahead and get this closed up, get it running, and then we'll look at these afterwards and make sure that they've become sterile. Okay, so this is the instrument pack that we wrapped earlier. So you can tell that it has been through the autoclave because our steam sterilizer tape has black lines indicating that it has been exposed and is sterile. These steam sterilizer indicators react to the heat as well as the time, and to a certain extent some of them due to the pressure. And so for autoclaves, for a general pack like this, 250 to 270 degrees. They're going to hold it at 15 to 27 psi and anywhere from 3 to 15 minutes. For these big packs, typically it's a longer cycle. So we're going to open this pack up and look inside at the inner sterilizer strip and show that it is sterile as well. And so we place this sterilizer strip in the center of the pack because we want to make sure that steam gets all the way to the center. So this is our sterilizer strip. Everything on here is black, the O, the K, and the arrow. And so that's an indicator that it has been steam processed and has reached sterility inside the pack. So when these get opened up in surgery, we always want to check these as we're opening the packs and make sure that the steam got all the way through the pack. Okay, so when we talk about suture, we talk about a couple of different things. So one is the material that it's made of, and whether it's absorbable versus non-absorbable, whether it's a monofilament or like a braided. We also talk about how thick the suture is. So we have things like 3/0, which is kind of a standard suture. 4/0 is actually smaller, so when you have a number in front, the higher the number, the smaller the thinner the suture is. But then if you go down to smaller numbers like a 2/0, 2/0 is going to be bigger than a 3/0. And then when you get into just single numbers like 0, 1, 2, those are going to be much larger sutures. We also talk about whether the needles are swagged, meaning they are all one piece with the needle, or with the suture it's a continuous, or whether it has to go through an eyed needle. Like this does not come with the needle attached, so you pull this off the spool and then you're actually going to thread it through an eyed needle. We also talk about the needle itself. So on something like this is a reverse cutting needle. This is going to be something that you're going to use for tougher tissues, for body walls and muscles and skin, whereas you have something on a taper, which is a round needle, so you're going to use this on more delicate tissues, though this particular suture is a non-absorbable suture, so it's meant more for external use. We also have some chromic gut suture. This is for very short-term things typically. We use that for stays for holding organs during surgery. We also use it for like our declaws. It's not used a ton anymore internally in major surgeries. So we have all of our different types of sutures, and typically it's the doctor's preference what they're wanting to use, but you can often at least get a base where to start by knowing what type of suturing they're going to be doing, and then also where in the body, whether it's something that's internal that's going to need to be absorbable, or whether it's an external skin suture where you could use something that's not absorbable. Okay, so this is Blue, and we're going to be taking his sutures out today. We're first going to look at this incision. It's nice and together. The edges have healed very nicely, so these sutures are ready to come out. If there were any gaps in the incision, or if there was any significant discharge or dehiscence of the incision, we would want to have the doctor look at this before we take these out. But these are looking good. So we're going to take our suture scissors, and we're going to take this little hooked end here, and we're going to hook it under the suture and snip it, and then pull that suture out. You want to cut the suture pretty close to the knot. Sometimes these sutures have multiple layers, and you don't want to go through multiple layers because then you'll end up with a piece of suture that gets hung. So we're just gonna go down the line and take these out.